My PPT is visible, no? My screen is visible?
Yes, ma'am, perfectly. Just make it full screen.
It is already full screen only. Means, okay, you are saying now. Yeah, now it is okay?
Yes, ma'am, perfect.
Okay. Yeah, good evening, everyone. So this NNF Shine is a very good initiative by Sushma ma'am, like educating all the postgraduates. So that's a very welcome change that is happening in our country. This is so today's session is regarding fluid management and neonatal shock. So you all know that giving fluids is the most basic care in any NAC, right? So we have to do it correctly. Neonatal shock is another very common morbidity that we come across in newborn infants because their cardiac and vascular system is very immature and they are very prone to develop shock. So both of these are very important topics, and we'll see what like how to go about. So we'll start with the first topic, that is fluid management. Uh, okay. So, as we said, maintenance of fluid and electrolyte balance is an integral aspect of neonatal care. So, you all know that breast milk is is the best food for the newborn infants, right? So, if any baby can feed, then leaving the baby alone on direct breastfeeding is the best thing that we can do for the neonate. So, fluid is only for those neonates who cannot take feeds, either direct breastfeeding or feeding by sung feeds or feeding through the gavage, that is the orogastric tube. So otherwise, for all clinically stable newborn infants, the breast milk is sufficient to maintain fluid balance because breast milk is designed by God to suit all the needs of a newborn infant. So only sick newborn infants will need IV fluids and electrolytes for sustenance. So why should we like the main goal of giving fluids is to allow normal weight loss, ensuring physiological stability. So we all know that all newborn babies, any baby who's born, should lose weight, right? So for example, term babies should lose up to 10% of will lose up to 10% of body weight. I mean from the birth weight, will lose up to 10% from the birth weight, and preterm infants will lose up to 15% from the birth weight. So this also should be ensured. So just because we are giving fluids, we should not overload the newborn infant, and we should not or to say allow we should not allow the baby to gain weight from day one onwards. So that is not good because it is normal for a newborn infant to lose weight. And why is it so? Why is a newborn infant losing weight soon after birth? It is because of excess body fluid, especially excess body water, especially the extracellular fluid. So newborn baby, when the baby is born, will have excess of extracellular fluid. So that excess fluid will be lost in the first week of life. Okay, so that is why newborn babies lose weight. So we have to ensure that the baby loses weight, at least around 10% in term infants and up to a maximum of 15% in preterm infants. Okay. So the learning objectives of this presentation would be, so we have to identify babies who need IV fluids. So what we have to understand is, as we already discussed, not all admitted babies need IV fluids. For example, if you're admitting a baby for neonatal jaundice and if you just want to give phototherapy, you can give the baby feeds itself and give phototherapy. So not all babies in the NICU or in your nursery will need IV fluids. Okay, so we have to identify which baby needs IV fluids, and then we have to calculate the daily fluid and electrolyte requirement. And we have to administer IV fluids using proper equipment. So that is, we have to use either a micro drip infusion or a syringe pump. And any baby who's on IV fluid will need constant monitoring for the IV line, the fluid status, etc. And if we start feeds also along with IV fluids, we have to keep on adjusting the IV fluids for the entry feeds. So we'll see about all these aspects one by one. Okay, so first is indication of IV fluids. So which baby will need IV fluids? So any sick baby who's not tolerating enteral feeds. So this not tolerating enteral feeding may be due to various reasons. For example, in a preterm baby, it can be because of necrotizing enterocolitis. In a term baby, it can be because of some congenital anomalies of the gut, or it can be because of general status, a general hemodynamic status of the baby. Like for example, a baby is in shock, okay, decompensated shock. So such general conditions. So the not tolerating enteral feeds is a generic term, and the non-tolerance of enteral feeds may be due to various reasons. Okay. Then any baby with shock. So especially if a baby is on multiple inotropes and baby is not maintaining blood pressure and baby has signs of poor peripheral perfusion, then we usually withhold feeds for a while. So such babies will need IV fluids. Then severe perinatal asphyxia. That is like, for example, stage 3 HAE. So baby is having repeated episodes of seizures. Baby is in a very, again, like both central nervous system wise and hemodynamics wise, baby is sick. So such babies also may not, like we usually don't give enteral feeds. Then, as we already said, abdominal distension, that is, which can be either due to congenital GI anomalies or necrotizing enterocolitis. So these are the common indications to give IV fluids in neonates. So which fluid will you choose? So in the first 48 hours, we have to give only 10% dextrose for the newborn infants. In preterm infants, sometimes we give calcium also, but then calcium, the problem is like we cannot infuse calcium through the peripheral IV cannula. So because if it extravasates, then it will cause severe damage to the skin and subcutaneous tissue. So extravasation of calcium is very dangerous. So if you like, you can, if you don't put an umbilical venous catheter maybe at the central line, then it is better to give only 10% dextrose. In the preterm infant, that baby, if the baby has a central line, then we can add calcium alone along with 10% dextrose for the first 48 hours. So first 48 hours, we have to give only a electrolyte-free fluid for the newborn infant. So, sorry. So when do we start sodium supplementation? Sodium supplementation is started only after 48 hours and after ensuring that the baby has adequate urine output and to some extent some weight loss also. So usually we say once the baby loses 5% body weight, birth from the birth weight, then you start so electrolytes. So that is another way of looking at it. So there are many ways of deciding when to start the electrolyte supplementation. One, like how we said, after 48 hours. So first 2 days you give only plain 10% dextrose. And then from third week onwards, you start adding sodium and then if required, potassium and other electrolytes as well. So that is one way. The other way is once the baby loses 5% of weight from the birth weight, that may be like another cutoff to start sodium supplementation in the IV fluids. So what kind of fluid we have to give after 48 hours? So usually we prefer giving isolate P because it is a ready-made solution. If otherwise, if in your unit, if you are preparing your own fluid, then you can prepare and give also. Like you can take 10% extras or 5% extras, add the amount of sodium, potassium, and calcium the baby needs, and then infuse that also. So that is one way. But then the risk of contamination, the risk of error due to mixing of all these electrolytes is always there. So we can always use a readily available fluid, that is our isolate P. So first 48 hours, give only plain 10% dextrose. At the end of 48 hours, start fluid containing all the electrolytes, such as usually isolate P. Okay, then how should we administer this IV fluids? We have to use a micro drip infusion set. So all of us would have seen, no, a micro drip infusion set. So the normal IV set that we use in adults, so which it is very like it is not suitable for newborn infants because there 1 ml is equal to 16 drops. Okay, we have to use only a micro drip infusion set here. In a micro drip infusion set, 1 ml is roughly taken as 60 drops. So usually we say 64. 60 is also okay. It is easy for us to calculate. So in a micro drip set, 1 ml is equal to 60 drops. And 1 minute has 60 seconds, right? So it will be easy for us to titrate the number of drops also. So for example, if I want 5 ml per hour, then I have to just keep 5 drops per minute. So if I keep the speed in such a way, if I adjust the knob in such a way that there are 5 drops of fluid falling into the chamber in 1 minute, then that means I'm giving 5 ml per hour. So the number of drops per minute is equal to the ml per hour that we want to infuse. So in that way, it is easy to calculate using the micro drip infusion set. Another advantage is we can fill less volume into the burette. Okay, for example, if a baby requires total 100 ml in 24 hours, just for an example I'm saying, then you can just put only the fluid that is required for 8 hours alone. So that is like 1/3. For example, 33 ml alone, you can put in the into the burette, and remaining you can leave it in the main fluid container itself. Otherwise, if we connect directly, like in adults, then if by error the fluid runs faster, then all the 500 ml fluid will run into the baby, which will be very dangerous for the baby. Okay. So you keep only the amount of fluid that is required for 8 hours inside the burette. So the remaining can be left inside the the fluid container itself. So that is another advantage of using a micro drip infusion set. So please use a micro drip infusion set to give IV fluids to a newborn infant. But if your NICU has an infusion pump or a syringe pump, then that will be the best way to give fluids to newborn infants, because that is much more precise. Like you can directly set 4 ml per hour, 4.2 ml per hour. And nowadays we have syringe pumps with two decimal points also. So you can even set 4.25 ml per hour. So it is like that accurate. Okay, so if you have a syringe pump, you should prefer using a syringe pump to give fluids. And if you do not have a syringe pump, you have to use a micro drip infusion set. So do not use the normal IV set that we use in adults. Okay, because that will be too dangerous to use in a newborn infant. Okay, so adjust the drip rate carefully and check it periodically to ensure delivery of correct amount of fluid. So this is also important. For example, like you have taken 33 ml in the burette and you have connected at 6 drops per minute or whatever, like depending on the baby's weight and fluid requirement. After a while, like for example, half an hour or at least 1 hour, please check whether it is going at the correct speed. Because sometimes we keep during that time 6 drops may be falling, and after some time, due to some reason, it may be running faster also. So we have to always make sure that the fluid is coming at like running at the correct rate. So if we are keeping 33 ml at 6 ml per hour, then after 1 hour, there should be remaining 27 ml fluid in the burette. That also we have to ensure. So please count the number of drops that are falling in each minute. And at the end of each hour, check how much of fluid is remaining so that we'll know like whether the fluid is going at the right rate. Okay, so and as we said, syringe pump is a more reliable way to deliver small volume of fluids and medications in sick babies. So here we have a pressure monitoring line, PMO, which is connected to a syringe. So in the syringe pump, as I said, you can set the rate, and then that much of fluid will be infused into the baby automatically by the pump itself. Okay, so for administration, so the bottom line here is for administration of IV fluids in a newborn infant, if you have a syringe pump, use a syringe pump. If you do not have a syringe pump, use a micro drip infusion set. Okay, then how do we prepare the fluid? So sterile aseptic precautions is very, very important, because as you all know, neonatal sepsis is one of the leading causes of mortality, not only in India, even in all the Western countries, all the developed countries also. Neonatal sepsis is a very common reason for mortality. So asepsis should never be broken inside the NEC. Okay. So wear sterile gloves while you are preparing the IV fluid or preparing the medication. You have to wash your hands. So hand hygiene is very, very important, and wear sterile gloves. Okay. And then what you have to do is for fluid calculation, calculate for 24 hours, like how we already discussed. We'll see how to calculate in the subsequent slides. So you calculate the total fluid that is required for 24 hours. And then in the burette, you fill only fluid that is required for 8 hours or 6 hours, depending on the the shift in your hospital. For example, some hospitals have shifts of 6 and 12 hours for the nurses. Okay. And some hospitals have equal 8 hours shift. So depending on the nursing shift, you can set the like you can fill the burette. For example, if the nursing like shift is only for 6 hours, you tell the nurse to fill only the 6 hours fluid inside the burette, so that when the next nurse comes, she can fill the fluid for her shift alone. So then that nurse will be able to check the rate of fluid infusion properly. Otherwise, if the previous nurse has kept and this nurse is coming now, and she also will not understand how it is going. So one nursing shift, that much of fluid, whatever fluid is required for one nursing shift, only that much of fluid should be kept inside the burette of the micro drip set. Okay. So maintain strict input-output chart and review it every 8 hours. And like when we are calculating the amount of fluid that has to be given to the neonate, for example, I have a baby and I want to give 100 ml per kg to that newborn infant in 24 hours. That 100 ml per kg should include all the IV medications also. Okay, because most of the IV medications that we use in newborn infants, we cannot give direct push. Okay, except for very few like ampicillin. All the other medications have to be given as an infusion. All antibiotics like meropenem and all other medications, even paracetamol. Okay, there is no direct IV push. Everything you have to dilute it in certain volume. You have to infuse it over a period of time. Okay, so all that is volume. So you have to account for all those volume. For example, a baby is on antibiotics. Okay, and the antibiotic has to be given twice a day, and each time you have to dilute it in 5 ml of fluid. So 5 ml plus 5 ml is 10 ml. So that 10 ml also should be included in this total 100 ml fluid per day. Okay. Similarly, when we are starting feeds, so we'll discuss that subsequently. So when you are starting feeds, you have to calculate how much of feeds the baby is receiving and minus that from the total volume of fluid that you are going to give to the baby. So whenever, so you are deciding the total volume of fluid per day, that volume should include the medications and should include the feeds. So you add up the amount, total amount of feeds that the baby will receive for the next 24 hours, and then you add up the fluid that is required for giving the medications, and you minus that volume from the total volume of fluid to be given to that baby on that particular day. And remaining fluid only you should calculate and keep it in the urine set. Okay, so we'll see examples subsequently when you will understand better what I'm trying to say. And securing the IV cannula is very, very important. One is like the IV cannula should not come out. And the other reason, other more important thing is like we have to use a skin-friendly adhesive tape. So, for example, if you use a Dynaplast directly on a preterm
ಅವ್ರ ಜೊತೆ ಒಂದ್ಸಲಿ ಊಟ ಮಾಡಿದ್ಯಲ್ಲ
ಊಟ ಮಾಡಿದೀನಿ ಬಟ್ ನಾನು ಹೇಳೋದು ಸೆಕೆಂಡ್ ಇಯರ್ ಅಂತ
someone do some bloody anesthesia and can I have the file ಅಂತ ಕೇಳಿದೆ ಓದ್ತಿದ್ದೆ ನನ್ ಕಾಲ್ ಅಲ್ವೇ ಅಲ್ಲ ನಾನು ಯಾರ್ದೋ ಕಾಲ್ ಹೋಗಿರೋದು
ಹೇಳ್ದಲ್ಲ ನೀನು ಅವತ್ತೆ
She's like you should which year ಅಂದ್ರು first year ಅಂತ you should call ma'am.
Okay, sorry for the interruption. Dr. Prerna, you can please mute yourself. Okay, so securing the IV cannula is also equally important. So use a proper tape so that the cannula does not come out. But at the same time, make sure that you use a skin-friendly adhesive tape. So what we do, like most of the NICU do, is we have something called as a deoderm or a hydrocolloid dressing. Okay, we put the hydrocolloid dressing down and then on top of it, you can paste your Dynaplast. Or you can use something which is much more skin-friendly like a Tegaderm or something. So whatever adhesive tape that is being used in your NICU, so please make sure that it is skin-friendly and it is not too harsh on the baby skin. So while removing, you have to be very, very careful. Like you should not peel off the baby skin along with the adhesive tape. Okay, and generally there is no need to splint the extremity. So usually we don't use splint routinely in newborn infants. Sometimes when it is a like very difficult line or if the baby is very vigorous, then rarely we use. Otherwise, usually we don't use splint in newborn infants. For pediatric patients, we routinely use it, no, because they are more mobile and like for them, keeping the cannula in place is more difficult. Whereas newborn infants is not that active. They are active, but they are not so active that to the extent that they'll remove the IV cannula. So usually they don't need a splint, but splints are rarely used in some exceptional cases. Okay, so and then regarding the fluid, so we already discussed about which fluid to use. So we have to use 10% dextrose in the first 48 hours and isolate P after 48 hours. But then while taking the fluid, please make sure that the expiry date of the fluid is not over. Okay, because sometimes no old hospital stock they may give by error, so you have to make sure that the like expiry date is not over. That is number one. And second, the seal of the infusion bottle or the bag for its intactness. So there should not be any leak or anything on the bottle or on the plastic container in which the fluid is stored. Because if it is so, then the fluid might have been already contaminated. So we cannot give a contaminated IV fluid to a newborn infant. And third thing is make sure that the fluid is clear and free from any visible particles. So that is also important. Sometimes some of the electrolytes will precipitate inside the fluid. So if you infuse such a fluid into the newborn infant, it may go and block the vein, it may cause an embolism, and it may cause all the other complications also. Okay, so these things should be ensured before we connect the IV fluid to the newborn infant. And every 24 hours, we have to change the infusion set and the bottle. For example, if you are taking a 500 ml of isolate P and if you are connecting the burette set to it, so at the end of 24 hours, change the isolate P also. Even if you have, for example, out of the 500 ml, you have used only 100 ml in 24 hours. It's okay. Please discard the remaining fluid and take a new bottle and take a new burette set. Because in 24 hours, because the fluid is hanging in the open NICU, right? So there is risk of contamination. So the risk of sepsis will increase if you keep running the same fluid day after day after day. Okay, so it is better to change the fluid and the burette set, the entire set every 24 hours. So this is again to avoid the risk of contamination and to avoid neonatal sepsis. Okay, so now coming to the volume of fluid that has to be given to a baby. So this differs from unit to unit and from one neonatologist to the other, but this is like these are the general guidelines most of us follow. Okay, so if the birth weight of the baby is more than or equal to 1.5 kgs, that is 1500 grams, then we can start with 60 ml per kg per day on day 1. And then we increase by roughly 15 ml per kg per day every day. This 15 ml is not a constant number. We have to adjust it depending on so many factors. We'll discuss some of these factors in the next few minutes. But in general, if everything is okay, then we roughly increase by 15 ml per kg per day. Okay, so for babies more than 1.5 kgs, start at 60 ml per kg per day and increase by 15 ml per kg per day every day and up to a maximum of 150 ml per kg per day. So if a baby is on only IV fluids, we usually do not cross 150 ml per kg per day unless there is a need to do it. Okay, for example, you have a baby with large volume diarrhea, or if you have a baby with some repeated episodes of vomiting where there is ongoing loss that you have to replace. In such cases, we go beyond this. Otherwise, in general, for all the well newborn infants or otherwise sick newborn infants, we do not cross 150 ml per kg per day. Okay, that is the maximum fluid that we give if we are giving only IV fluids. If we are giving feeds, then sometimes we go beyond that. That's a different situation. Okay. Now for babies for less than 1.5 kgs, that is preterm, most of these are preterm infants. So in these babies, we start at 80 ml per kg per day on day 1. And then again, we increase by the same 15 ml per kg per day every day up to a maximum of again 150 ml per kg per day. Okay, so and as we said, the volume of fluid is usually told in terms of how much of ml per kg per day. For example, if I say 60 ml for a 2 kg baby, I'll be giving 60 into 2, that is 120 ml. Okay, so in 24 hours. So for one day, for every kg of weight, what is the fluid that is required? So you have to multiply this number with the weight of the baby, and then you have to infuse that much of fluid to the baby over the next 24 hours. Okay, so as we said, volume of fluids depends on birth weight, gestational age, and postnatal age. And the fluid requirement of preterm infants are more as compared to that of term infants. So we all know this, right? So that's why in preterm babies, we start at a higher volume, so 80 ml. Whereas in term infants or even late preterms, we start at a little lower volume. Okay, so why is this so? This is due to so many reasons. The main reason is the preterm babies have more total body water and they like their skin is very immature, so their insensible water loss is much higher when compared to that of term infants. Term infant skin is all the more mature, whereas preterm babies, the skin is much more immature and their body surface area is also more. So they tend to lose more water through insensible water loss. So they tend to lose more weight also. So the amount of fluid they need is also more when compared to that of term infants. Okay, so like now how much kilocalories I have to give for the baby? So a baby needs calories for so many reasons, right? For example, a baby loses energy or spends energy for certain things, and then we need energy for storage, for excretion, for activity, etc. So, for example, if we see on a like day-to-day basis per day, the energy expended, that is the energy the baby utilizes, is around 40 to 60 kilocalories per kg per day. And of this 40 to 50, almost most of it is for RM, like resting metabolic rate. Okay, so that is for the normal metabolic processes that are happening in our body, like for the heart to beat, for our breathing, for all the cellular activities, etc. So that is the resting metabolic rate. Okay. And then we need around 0 to 5 kilocalories for activity, because as we already said, newborn babies don't move much. They don't need so many calories for activity. They need only around 5 kilocalories maximum for activity. And then for thermoregulation. So though we try to maintain the baby's temperature through various mechanisms, still the baby will need may need to produce some heat. Okay, so around 0 to 5 kilocalories will be required for thermoregulation. Then for synthesis, because a newborn baby especially, is growing very fast, right? So it is one of the fastest growth period in a human life. It is the fastest growth period in a human life. So for even if you take a term baby, it has to gain at least 30-gram weight per day. So that means the baby needs a lot of energy for synthesis, for protein synthesis, for fat synthesis, etc. So for synthesis, baby will need around 15 kilocalories per kg per day. For energy storing, again, same thing for accretion, either protein accretion or fat accretion, whatever you want to call it is. So that will be around 20 to 30 kilocalories per kg per day. This is like for growth. Then energy excreted is around 15 kilocalories per kg per day. So if you add all these together, the total energy intake a baby would require will be around 90 to 120 kilocalories per kg per day. So this much kilocalories we have to give for a newborn infant. So 90 to 120 kilocalories per kg per day. Okay, so now we'll see an example. So it is calculation time as it is given here. For example, we have a 4-day-old neonate with a birth weight of 1.2 kg. So what will be the total fluid requirement of this baby? So we already said if a baby is less than 1.5 kgs, we'll start with 80 ml per kg per day on day 1. So day 1 it is 80, and day 2 it will be 95. So if we see here, so day 1 it is 80, day 2 will be 95, day 3 is 110, and day 4 is 125. Okay, so this baby will need 125 ml per kg per day of IV fluids. So how do we calculate? So as per the table, this baby requires 125 ml per kg per day. And what is this baby's weight? 1.2 kg. Okay, so 125 into 1.2 is around 150 is 150 ml. So this 150 ml we have to infuse over 24 hours. So for this baby. So if you divide this 150 divided by 24, it is around 6.2 ml per hour. And as we already discussed, we should not keep all the 150 ml into the burette set. Burette set, I don't think we can keep 150. I think the maximum is only 100. So even 100 we should not fill. So we should fill only the fluid that is required for 8 hours inside the burette set. So for 8 hours means it is roughly around 50 ml, right? So 8 into 6.2 is around 50 ml. So fill only 50 ml inside the burette set. And then what you will do, if you are using a burette set, then fill 50 ml and keep it at 6 drops per minute, because this baby needs 6.2 ml per hour, which is roughly around 6 ml per hour. So if you keep 6 drops per minute in the micro drip infusion set, it will be equal to 6 ml per hour, which is roughly equal to 6.2 ml per hour. Okay, because that is the maximum we can do. We cannot it is not possible to titrate to 6.2 ml using a micro drip set. But if you have a syringe pump in your unit, then you can connect the syringe to the syringe pump and you can set 6.2. Then the syringe pump will be giving 6.2 ml every hour. Okay, so this is how we have to calculate the fluid. So first find out for this this body weight and for this day of life, how much fluid I have to give in terms of ml per kg per day. Okay, and then you once you you refer to the table and find out how much ml per kg per day I have to give. Then multiply that with the weight of the baby. So you'll get the total fluid volume that has to be given over 24 hours. Okay, so here we got around 150 ml in 24 hours. Then if you divide that by 24, you will get the ml per hour number. If you have a syringe pump, you can keep that ml per hour in the syringe pump directly. If you do not have a syringe pump, then you have to use a micro drip infusion set. In the micro drip infusion set, You fill the burette only with the amount of fluid that is required for 8 hours. Okay. So fill only 8 hours fluid inside the burette and you keep how many ml per hour? So that many drops per minute you have to set. So for example, here it is roughly 6 ml per hour. So you keep set it at 6 drops per minute. So which will be roughly equal to 6.2 ml per hour. Okay, hope this is clear. Okay, so now moving on to the next thing, like how do we monitor the baby on IV fluids? So as we already said, like newborn babies, the IV line is a very vital component. Okay, one is like we have to make sure that it is inserted using strict aseptic precautions. And then every time you handle the IV line also, you have to maintain strict asepsis. Okay, and you have to make sure that it is inside the vein, because newborn veins are very small. It's not like a 10-year or 12-year-old child. Okay, so the veins will be very small. So the risk of extravasation is very high. Getting an IV line is also difficult, and then maintaining it is all the more difficult in a newborn infant compared to older children. Okay, so you have to check the infusion site every hour, at least once in an hour. Like make sure that there is no extravasation. That is the fluid is going on properly. So how do you identify extravasation? There will be swelling around the line, swelling and redness around the site of insertion of the cannula. So this indicates that the cannula is not inside the vein. The fluid is already leaking into the subcutaneous tissue. So if you find any swelling or redness, you have to remove the IV line immediately and you have to insert another IV line in a different way. Okay, so that is now number one. So check the infusion site. Number two, we already discussed. Check the volume of fluid that is infused. For example, this baby, you are filling 50 ml in the burette set and you are keeping a 6 drops per minute. Okay, after 2 hours, if you check, only 12 ml fluid should have gone. Remaining 38 ml of fluid should be remaining inside the burette set. So check both, how many drops is falling each minute. That's how you can spend 1 minute and count the number of drops. That is number one. And number two is how much fluid is remaining in the burette set. Okay, so you know when you have connected the fluid, no? So if you check how much fluid is remaining, then you will know how much of fluid has gone until now. So that also should match. So this you like monitor this also and record this also every 2 hours in the fluid monitoring chart. And then measuring blood glucose is very important. One, newborn babies are very prone to hypoglycemia, right? So, for example, if the fluid is getting extravasated, fluid is not going, baby sugars will drop. Okay. So, measuring glucose is another way. And it will also hint you if the blood glucose level is suddenly increased, then also you have to check the fluids. Maybe fluid has gone very fast. Okay. You can find out both the fluid not going as well as fluid going excessively depending on the blood glucose levels. So at least once in every nursing shift, that is 8th hourly, we have to monitor the blood glucose in any baby who's on IV fluids. Okay, so when you are monitoring the blood glucose, if the blood glucose is less than 45, you have to treat the baby for low blood glucose levels. So in newborn infants, usually we take the cutoff of 45 in the first 48 hours, 48 to 72 hours, and after 48 to 72 hours, our cutoff is 60. These are the general cutoffs that we follow. Okay, so 45 in the first 48 to 72 hours and 60 after 72 hours. Okay, so if the blood glucose is low, one, you check whether the fluid is going properly, and then you have to treat the low sugar also. Similarly, as I said, if the blood glucose is more than 150, then you will have to like check whether the fluid is going correctly. That is the first thing, because most of the times it may be because of the fluid going very fast. Okay, if the fluid is going properly only, still the baby is getting high glucose levels, then that means even that normal glucose infusion rate, baby is not tolerating. Then you will have to cut down on the glucose that they are giving to the baby. Okay, so then what are the other monitorings that we have to do? Weight. Weight is very important. Every day we have to check weight, preferably electronic weighing scale. Okay, so use electronic weighing scale and check the weight. And it is said that the weighing machine that you are using should be like accurate enough to detect at 5 gram or at least 10 gram weight difference. Because most of the times our babies are 1.2, 1.3 kg babies. For them, even 10 gram weight difference.
అంటే ట్యూబ్ బేసిస్ మీకు చెప్పారా ఏం కనపడింది మీరు బాగానే లేదని చెప్పారు
Okay.
మానస మేడం అన్నారు మేడం గురించి మాట్లాడారు
Okay, and the next thing to check is the urine output. So urine output. So usually, like if you can monitor the ml per kg per hour, then that will be the best thing. So the urine output should be more than 1 ml per kg per hour and less than 4 ml per kg per hour. So the normal urine output in a newborn infant is anywhere between 1 to 4 ml per kg per hour. But if you cannot monitor the weight by weighing every time, then you have to go with the number of times the baby is passing urine. Okay. So usually in the first 40 to 72 hours, like once or twice a day urine output is enough. That's what we say. But in a baby who's on IV fluids, usually baby will be passing a little more urine. Okay, but after 48 hours, then the baby should be passing at least 5 urines per day, minimum 5. Okay, roughly we say 6 to 8 times urine per day. Okay, so like this also you can monitor. So what, as we said, oliguria is defined as urine output of less than 1 ml per kg per hour. And every 6 hours you monitor the fluid. So because you cannot keep on writing the ml and then finding out at the end of 24 hours that the baby has been oliguric for 24 hours. Okay, that is not acceptable. So urine output, if it is low, you have to find it out in the next 6 hours. So if the baby is not, if you think that the baby is not passing adequate urine, please. So please measure the urine output like in terms of ml per kg per hour over every 6 hours period. Okay. And then signs of overhydration, like as we said, fluid has run too fast or due to some reason baby is not able to tolerate even the normal volume of fluid. So that also we have to identify. The signs of overhydration includes puffiness of the eyelids, excessive weight gain, or if it is too much, then baby may even go into pulmonary edema and may go into respiratory distress. Okay. Okay, so we already said about like how to calculate fluids. Now the another important thing that we have to consider is which weight I will take. Okay, while calculating IV fluids on day 1, day 2, what weight? Because there is a birth weight and there is that day's weight, today's weight. So which weight should I take? So it is a very important consideration. So usually what we do is until we already said babies lose weight. Okay, term babies lose up to 10% weight and preterm babies lose up to 15% weight. So once during that weight loss period, we take only the birth weight of the baby for all the calculations, for calculating fluids, for calculating medications, everything. Okay. So until the baby is, whenever the baby is below birth weight, take birth weight for all the calculations. Once the baby crosses birth weight, which usually happens by around day 10, day 7 to 10 in a term infant, and day 10 to 14 in a preterm infant. Okay. So after that period, you use the current weight. That is the today's weight of the baby. Okay. So until the baby, during the weight loss phase, until the baby crosses or reaches back to birth weight, use birth weight for all the fluid calculations. Once the baby has regained birth weight and started gaining weight beyond the birth weight, then you take the current weight of the baby for all the fluid calculations, all the fluids and medications calculations. Okay. So then, like, how do I go about depending on the weight? So we usually expect 1 to 3% weight loss every day. Okay, and even more than 3 is more only. But if it is more than 5%, then it is definitely more. So usually babies don't lose more than 3% weight in a single day, and the cumulative weight loss is 10%. Okay, so when these numbers are exceeded, for example, if the daily weight loss itself is more than 5%. Then you can increase the volume of fluid. For example, every day we said like we'll increase by 15 ml. Okay. But if that with that increase, if the baby is losing more weight, then you can increase another 10 ml also. So instead of increasing by 15 ml, you increase by 25 ml per kg. Okay, if there is excessive weight loss. Similarly, if there is no weight loss or there is weight gain in the initial, we already said the first of 3 to 5 days, baby should lose weight. Okay. But in the first 3 to 5 days itself, baby is gaining weight. That means whatever fluid we are giving, the baby is not tolerating. Baby is going into a fluid overload phase. Then you cut on the fluids. So don't increase the fluid, or even whatever fluid you are giving, that also you can reduce and see. So we have to allow for the normal postnatal weight loss. That's what we already discussed. Okay. So depending on the weight, like you have to adjust the fluids. So this 15 ml per kg per day increase is only a rough guideline. Okay. If the weight loss is more, for example, if it is more than 5%, you increase the fluid more. If the weight loss is if there is no weight loss in the initial 3 to 5 days, or if there is excessive weight gain, baby is gaining weight by 5% even after 5 days. Okay, so then that is also wrong. That means we are giving too much fluid, or whatever fluid we are giving, the baby is not able to tolerate. Then you cut back on the fluids. So all these adjustments we have to do. Okay, yeah. So far we were talking about urine output and weight going hand in hand. So what if the baby is oliguric but baby is gaining weight? That means there is something wrong. Okay, so that means baby is in AK, that is acute kidney injury. So baby is not passing urine and baby is retaining fluid. Okay, so what do we do? What should we do in a baby who is having AKI, that is acute kidney injury? So what we have to do is we have to give only insensible water loss plus urine output in these babies. Okay, this is what we do in older pediatric patients also, right? Same thing we have to do in newborn infants. So how much fluid we have to give in a baby who's oliguric? If we see that the amount of fluid should be equal to insensible water loss plus urine output in the previous 24 hours. That much fluid only you have to give over the next 24 hours. Now, how much is insensible water loss? Usually we take it around 25 ml per kg in a term infant and 50 ml per kg in a preterm infant. So in a preterm infant, depending on how preterm the baby is, this number varies, but in general, you can take it as 50 ml per kg per day. Okay, plus urine output of the previous day. So this much fluid only we have to give in a baby who is oliguric. Okay, and what do we replace with? So usually urine we'll replace with half normal saline, that is half NS, like whatever you want to call it. Okay, N by 2. So urine will replace by half normal saline, and you will have to give some dextrose also. So depending on that, you can choose the fluid that you want to give. Usually we will not give isolate P in a baby who's having oliguria, because isolate P has all the other electrolytes also, like potassium, etc., which the baby will not be able to excrete. Okay. And so here actually we are restricting fluids, right? For example, in a term baby, it is 25 ml per kg, and baby has passed only around some 20 ml per kg in the previous 24 hours. Then that means we will be giving only a total of 45 ml per kg for the baby. Okay, in such a situation, always make sure that you are giving adequate glucose to the baby. Okay, just because you want to cut down on the fluids, the amount of glucose that is being infused to the baby should not be too less, because then that will result in hypoglycemia. Okay, so usually what is said is the endogenous production of glucose is around 4 milligram per kg per minute. Okay, and this is the lowest glucose infusion rate you have to maintain in any newborn infant. So so the fluid that you are giving, okay, should not give a glucose infusion rate of less than 4 milligram per kg per minute. 4 is the minimum GIR that you have to maintain in any newborn infant. Okay, so you have to restrict fluids. At the same time, you have to give adequate glucose. Both are equally important. Okay. Then other things. So we already said, like for urine output, will replace urine output with half normal saline, correct? So what about gastric aspirates or vomiting? So usually if it is a vomiting, it's non-bilious vomiting, okay? So non-bilious means it is coming only from the stomach, correct? So similarly, if the aspirate is coming from the stomach only, it's a non-bilious aspirate. So such things we will replace with half normal saline. Again, N by 2 or half NS. If it is bilious, if the gastric aspirate is bilious, or if the vomiting of the baby is bilious, then we usually replace it with ringer lactate or normal saline. And this replacement also should happen every 8 hours or every 6 hours also if it is too much. Okay, yes. Then fluids for dehydration, serial recording of weight is the most reliable way to assess the severity of dehydration. So in older pediatric patients, you look for so many other signs like sunken eyes, skin turgor, okay, all the other. These things are not very reliable in case of a newborn infant, okay, because they may be sometimes, if the baby is not thriving well also, baby may have sunken eyes, baby may have decreased skin turgor, etc. And most of the times newborn infants have hypernatremic dehydration, where your skin turgor will have a doughy feel. So you will not get that classical dehydration skin turgor how you get in older children. Okay, so because these are less reliable in terms of in newborn infants. So the best sign to assess dehydration is the amount of weight loss. Okay, so for example, if a baby has to lose only 10% weight, but baby is coming with 20% weight loss, then baby is definitely dehydrated. So the amount of weight loss is the best sign to assess dehydration in a newborn infant. Okay, and dehydration also should be corrected very slowly. Okay, usually we correct it over 24 hours. So we don't give your like for example in children and all you correct some dehydration over 4 hours and severe dehydration over 6 hours or even 2.5 hours like that. No, so that we don't do such corrections in newborn infants. Usually in newborn infants, dehydration correction is done a little slower. Okay, so how we usually do is half of the deficit will correct over 8 hours and remaining half is corrected over 16 hours. Okay, this is only for dehydration correction. This should be given along with maintenance fluid and the ongoing losses. See, for example, you have a newborn infant with diarrhea, not diarrhea, for example, hypernatremic excessive weight loss and dehydration, and baby has lost around 20% weight. Okay, so you accept it to 10% and the remaining 10%. Sorry for the interruption. My laptop got switched off. Just 1 second. I'll just share the screen again. Okay, sorry. So like what we were discussing is assessing dehydration in a newborn infant. It is difficult to go with the other physical signs. The best way to assess dehydration in a newborn infant is based on the weight loss. Okay. So, and correcting dehydration in a newborn infant also has to be done very slowly over 24 hours. So, half of the deficit is corrected over 12 for over 8 hours, and remaining half is corrected over 16 hours. So, the amount of fluid that is given during this 24 hours is one, we have to give the fluid for the dehydration correction. Two, we have to give the normal maintenance fluid. And three, we have to add the ongoing losses also. Okay. For example, if you have a baby with diarrhea and who is having 10% dehydration, you put half NS or like if you want to use RL because it is diarrhea, it's fine. So use the fluid for 10% dehydration plus the normal maintenance of the baby for that day. Plus you have to give fluid for the ongoing losses also. Like for example, if the baby has 10 stools in 24 hours, that also you have to replace with 5 ml per kg or 10 ml per kg for each stool, depending on the volume of depending on the rough estimate of the volume of each stool. So three different fluids you have to give. I mean, not three different fluids. So three different aspects you have to calculate and you have to add everything and give that much of fluid that is required for the baby. Okay. Okay. So if there is severe dehydration secondary to diarrhea, you can also use Plan C according to the IMNCA guidelines. So that is like the same 1 hour plus 5 hours in case of severe dehydration, 30 ml per kg over 1 hour and 70 ml per kg over 5 hours. That also can be done. And potassium, usually we add potassium in a baby with especially in a baby with dehydration. Add potassium only after ensuring urine output. Okay, because if the baby is having a reduced urine output and during that time if you are giving potassium, it may be very harmful to the baby. Baby may go into hyperkalemia and may start having arrhythmias. Okay, so only after ensuring adequate urine output you have to add potassium. And one ml of, so the normal KCl that we use, 1 ml has 2 milliequivalents. Okay. And roughly we add 1 ml of KCl for every 100 ml of fluid. So for example, if you are hanging a 500 ml bottle of either isolate, not isolate, of 10% dextrose with sodium or even half DNS or whichever fluid you are using, then you add 5 ml of KCl to that 500 ml. Okay. So that will be like 1 ml for every 100 ml or 2 milliequivalents for every 100 ml. So this is how we usually add KCl to the fluid. Okay, okay, so this is what we already discussed, right? So once we start, so usually on day one, if you have some concern, on day one of admission, you don't want to start feeds, you are giving only fluids. Okay, fine. By day 2, day 3, you are sure that the baby is not having any problem and it is time to start enteral feeds. Then when you start enteral feeds, you have to adjust the volume of feeds in the fluids. Okay, that is very important. And how much volume of fluid we have to give? So for preterm infants, usually we start by like 20 ml per kg per day and we increase gradually by 20 or maximum 40 ml per kg per day. Okay, for preterm infants. For term infants, like you can go up very fast or you can even start full feeds if the baby is stable enough. Like not very sick in case of sick neonates. Okay. So what we have to do is we have to subtract the daily volume of feeds and give only the remaining as IV fluids. And as you increase the feeds, if the baby is able to tolerate 100 ml per kg per day of feeds, okay, then it is time to stop the IV fluids and give only the feeds. So we'll see how this is done. So for this same baby, no, this is a different baby, okay? So this baby, a preterm baby, 31 weeks, 1.2 kg birth weight, maybe is hemodynamically stable, but only baby requires only CPAP or oxygen by nasal forms. So what will be the day one fluid orders? Okay, so there are two ways of going about this. So one you can start fluids and then gradually increase feeds. Or in a 31 weeks, 1.2 kg baby, some units start direct full feeds. That is also okay. Because there are RCTs, especially from India, many studies from India that says that for more babies more than 30 weeks, you can start full feeds on day one itself. Especially if you have a like a human milk available, either by human milk banking or mother, if the mother is able to give so much of feeds on day one. Okay. So what can we do? So one is like, so we'll see the first scenario where we want to give fluids plus feeds. Okay. So as we already said, because this is a preterm baby, how much fluid we'll be giving on day one? So we'll be giving 80 ml per kg per day on day one. Okay. And the baby's weight is 1.2 kg. So 80 into 1.2 is 96 ml. So 96 ml of fluid we have to give over 24 hours. Correct? Okay. And then I want to give 30 ml per kg per day feeds. So for this baby, 30 into 1.2 is around 36 ml. Okay. So total fluid volume that has to be given to the baby is 96 ml. So this 96 ml includes both fluids and feeds. Of the 96 ml, I want to give 36 ml as feeds. So remaining will be 96 minus 36. That will be around 60 ml. So remaining 60 ml I'll give as fluids. Okay. So minimal enteral nutrition is nothing but the less volume feeds of very low volume, either 20 or maximum 30 ml per kg, which we give to these preterm babies for gut priming. So we call it as either trophic feeds or minimal enteral nutrition. Okay. So that only we start on day one. Remaining we usually give us IV fluids. So the IV fluid requirement for this baby is 96 ml. And I want to give 30 ml per kg per day feeds, which is coming to around 36 ml for this baby. So 96 minus 36 is 60. So of this 96 ml, 36 ml I'll give as feeds and remaining 60 ml I'll give as fluids. Okay. So this much is clear. So now this 36 ml, how will I give? I'll give 2 hourly feeds, second hourly feeds. So if I give 2 hourly feeds, then I'll be giving 12 feeds per day. Correct? So 12 feeds means, so 36 ml I have to give us 12 feeds. So each feed will be around 3 ml. So how will I feed the baby? 3 ml second hour. So once in every 2 hours, I will give 3 ml feeds to this baby. So that will come to 36 ml in 24 hours. Okay, so this is about feeds. Now fluids, we already said. So 96 minus 36, 60 ml. So remaining 60 ml I'll give as fluids. And what fluid will I give for this baby? On day one, I'll give only a electrolyte free fluid, that is a 10% dextrose. Okay, so 10% dextrose I'll give. And we already said if we are using a microdrip set, we'll fill the burette with only fluid that is required for 8 hours. Okay, so so if it is 60 ml in 24 hours, then in 8 hours it is 1/3 of 60 ml, which is around 12 ml. Sorry, which is around 20 ml. So 20 ml I'll fill in the burette. And what is the drip rate? 60 divided by 24. So which is around 2.5 ml per hour. So how many drops will I set? You can set either 2 drops per minute or 3 drops per minute for this baby. So roughly 3 drops per minute if you keep, it will be around 3 ml per hour, which is roughly equal to 60 ml per day. So this is how I'll give fluids and feeds for this baby. Okay. So now second day, what will I do? Second day, I'll increase the fluids by at least 15 ml. Correct? So how much fluid I gave on day one? 80 ml. So on day two, I'm giving 95 ml. So I have increased by 15 ml. And 95 ml for this baby is around 114 ml per day. And feeds, how much will I give on day two? So day two, I'll increase the day one, I gave 30 ml. And day two, I can give up to 60 ml feeds. So 60 ml feeds for this baby is 72 ml. So remaining everything is same. So 72 ml, I have to give it in 12 feeds. So each feed will be 6 ml. So I'll be giving 6 ml second hourly feeds. Okay, 6 ml 2 hourly. And fluids, 114 minus 72, which is around 42 ml. So 42 ml, I'll give over 24 hours. So 42 ml means in 8 hours, it will be around 14 ml. And 14 ml every 8 hours I have to give. So it is around 1.75 ml per hour. So in the microdrip infusion set, you keep 2 drops per minute, which is equal to 2 ml per hour. Day 3. So day 3 again, so I'll increase the fluid again by another 15 ml, which will be around 110 ml. So then the total fluid volume is 132 ml. And feed also I'll increase. Okay, feed I'll increase to 100 ml, or if you want to increase by 30, it will be 90 ml. It's up to you. You can increase either by 30 ml or 40 ml per day, depending on the tolerance of the baby. So if you increase by 40 ml, it will be around 100 ml. So fluid itself is 120 ml, correct? So 120 ml is more than like 80% of 132 ml, correct? So you can stop the fluids now and give only feeds. So 120 ml, I have to give as second hourly feeds. So 120 divided by okay, so there is some confusion. So 120 ml, I'll give it over second hourly feeds. If I give, I have to give 12 feeds. So it will be 10 ml second hourly feeds. Okay. So if I give 10 ml second hourly feeds, it will be total of 120 ml. And because we have already crossed more than 80% or more than 2/3, whatever you want to take of the total fluid requirement, I can stop the fluids. As I increase the feeds, I can taper and stop the IV fluids. So this baby will need only, I would have required IV fluids for only 48 hours. By day 3, we were able to reach a sufficient volume of feeds and we were able to stop the IV fluids. Okay. So day 4, we have already reached full feeds, right? So there is no IV fluids. So I just have to increase the feeds to around 150 ml per day. So like 125 ml per 125 ml per kg per day, which is 125 into 1.2 is 150 ml. So 150 ml, if I want to give 12 feeds, it will be roughly around 13 ml. Okay, so 13 ml second hourly feeds. So you can increase the feeds by 30 ml per kg per day or maximum 40 ml per kg per day in these babies. And as you increase the feeds, the volume of fluid that is given to the baby will keep on decreasing. And if you are able to increase by 30 or 40 ml per kg per day, you will be able to taper and stop IV fluids by day 3 or maximum day 4 in most of the preterm infants. Okay, so now coming to the second scenario. So far we saw like if we start fluids plus trophic feeds on day 1 and then we gradually increase feeds by 30 ml per kg per day. How do we taper the fluids and how do we reach full feeds? That is what we saw. Now we'll see the second scenario where we are going to give full feeds to the baby from day 1. So the same baby, 1.2 kg baby, gestation age of 31 weeks. Baby is hemodynamically stable on CPAP or oxygen. And I want to give full feeds to the baby. How much feeds will I give? I'll give 80 ml per kg. Same 80 ml per the fluid requirement is the same, whether you are going to give it as feeds or fluids. So I want to give feeds only at 80 ml per kg per day. Okay. So 80 into 1.2 is 96 ml. And 96 ml, I have to give second hourly feeds means totally I'll be giving 12 feeds. So 96 by 12 is 8 ml. So I'll give 8 ml second hourly. So if I give every 2 hours 8 ml feeds, so that will be equal to 96 ml. But only problem is like this giving full feeds on day 1. If we give with the preterm formula, then the baby's tolerance may be a little difficult. If you have breast milk of the mother, which is less likely on day 1. If you have a milk bank, then you can definitely use donor milk and you can start full feeds on day 1 itself. Okay, so anyway, on day 1, even if you are giving full feeds, you will be giving only 80 ml per kg per day. And whatever volume you get, divide it into 12 feeds and give it every second hourly. So this is how we give full feeds from day 1 onwards. Okay, so to summarize the fluid management. So as we said, first 48 hours, use an electrolyte-free fluid. So usually we use only 10% dextrose in the first 48 hours. After 48 hours of life, you can use isolate P because it has dextrose, sodium, potassium, magnesium, everything is there. In isolate P, it is a ready-made solution. Okay, it will be easy for you to administer. So after 48 hours, use isolate P. And how should I infuse the fluids in the preterm or even a term infant neonate? We have to use ideally a syringe pump. And if syringe pump is not available, please use a micro drip infusion set. Do not use the adult IV infusion set in a newborn infant. And I have to monitor any baby who's on fluids. Okay, I have to monitor so many things. Like I have to monitor the IV site. I have to make sure that the fluid is going at the correct rate, like in terms of number of drops per minute. And I have to watch the serial weight. That is, every day I have to check weight and I have to check the urine output of the baby. So these two will give me hints as to whether I am overhydrating the baby or I am underhydrating the baby. So these two is the urine output and say daily weight check are the very good markers of assessing fluid balance in newborn infants. And enteral feeding should be started as soon as the baby is hemodynamically stable. Okay, just because the baby is requiring oxygen or just because the baby is on CPAP support does not mean that we should not feed the baby. Okay, in fact, most of the babies like late preterm or even moderate preterm babies who are on CPAP, we can give full feeds and keep the baby on CPAP. Okay, the baby will be able to tolerate it well. And so early enteral feeding is feasible, safe, early total enteral feeding. That is like how we discussed, no? The scenario 2. That is for a 31-week or 1.2 kg baby. We did not start any IV fluids. We started fluids from day 1. This is the scenario, second scenario. Okay. We gave 80 ml per kg per day feeds on day 1 itself. That is called early total enteral feeding. So it is feasible, safe, and advantageous, especially in a country like ours. Okay, so most of the times we are overloaded with our work. In our NICU, there will be some 50 to 100 babies. So our nurse will not be able to put IV fluids and monitor all the 100 babies. So in such situations, early total enteral feeding is very helpful. And the studies, as I said, most of it are done from India, and they show that it is safe in India. And it should be safe in all the NICUs. Okay. So if the neonate is stable enough, you can start early total enteral feeding. Okay, so with this, we are finishing the fluid management part. Now we are moving on to the neonatal shock. Okay, so what is shock? So we all know that shock means a state of poor perfusion. That means there is a decrease in blood supply to the vital organs of the body. So there is the perfusion of the vital organs is not met. Okay, a perfusion in turn, that is the demand of oxygen and nutrients of the vital organs is not met. So that is what is shock. So because of this, what will happen? So proper oxygen is not delivered to the vital organs. It will result in hypoxia. And hypoxia in turn will cause metabolic acidosis. So if once the metabolic acidosis reaches to a very, like once it becomes severe, it may cause even irreversible tissue damage. Okay. So the other thing what we have to understand is shock and hypotension. These are not synonyms. Shock means there is poor perfusion, there is reduced blood supply to the tissues of the body. Whereas hypotension means the blood pressure of the baby is low. Okay, and most of the times in neonates and even in older children, hypotension is a very late sign of shock. Okay, so we call it as compensated shock and decompensated shock, correct? So a compensated shock means baby has poor perfusion, but BP is maintained. Okay, this is like early shock. So if you identify the baby during this stage itself, then it is easier to treat the baby. So if we don't identify the baby during this stage, then the next stage, that is the baby will decompensate further. The BP also will drop and baby will go into hypotensive shock or decompensated shock. So during that time, like resuscitating the baby, I mean, the treating the baby will be all the more difficult, right? Because baby has already decompensated. Okay, so what we have to understand is shock and hypotension are not synonyms, and hypotension is the late sign of shock. So what is hypotension? Hypotension means the blood pressure of the baby is less than the expected reference range. Okay, that's all. And how do we measure BP in a newborn infant? It's very difficult because we cannot use a sphygmomanometer. We have to have a multi-parameter monitor to measure blood pressure in a newborn infant. We have cuffs, newborn size cuffs, like size 1, 2, 3. We have so many size cuffs. We can use those cuffs and do a non-invasive blood pressure monitoring. Okay, and even a non-invasive blood pressure, we can measure only if we have a multi-parameter monitor. And what should be the normal blood pressure in a newborn infant? It is still like very vague because nobody knows what exactly is the BP for each and every neonate. We have some charts. For example, the commonly followed chart is the Zubros chart. Okay, so that gives us what BP we have to maintain for each baby. But roughly, if you see that mean, if you see in a baby, the mean arterial pressure of the baby should be equal to the gestational age. This is a rough guideline we follow for all our clinical management. For example, we saw a 31 weeks baby, right? So in that baby, the mean arterial pressure, not a systolic or diastolic BP, this is mean BP. The mean BP should be equal to or more than 31. The 31 is a lower limit that we can accept. Okay, so MAP is roughly equal to gestational age. This is what we clinically use. Or you can use all the charts also to see what is the normal blood pressure for each unit. Okay, how do we identify shock? So most of the times tachycardia is the early sign of shock. Okay, so normal heart rate of a newborn is 120 to 160 per minute. So if we have unexplained tachycardia, so heart rate is more than 160, then that may be an early sign of shock. Okay, but you have to rule out all the other causes of tachycardia, like for example, fever, okay, or baby is having some pain due to some reason or some fracture or some NEC. There are so many causes of pain, right? Or even an extravasated IV cannula. All these are sources of pain. So pain also will increase heart rate. Fever or hyperthermia can increase heart rate, and some drugs like caffeine or aminophylline can increase heart rate. So if you rule out all the other causes of tachycardia, if there is an unexplained tachycardia in the baby, then that may be an early sign of shock. Okay, so number one is heart rate, and the other thing that we commonly check for perfusion status in a newborn is capillary refilling time. So we call it a CRT. The difference of checking CRT in a newborn when compared to that of older children or adult is, in adult or older children, we will check CRT over the peripheries. For example, you see over the finger or toes, correct, in older children. Whereas in newborn infant, we check central CRT. That is, we check capillary refilling time over the sternum, okay, on the chest. So what we have to do, we have to press for 5 seconds and release and see whether the whatever the blanch that we created refills within 3 seconds. Okay, so how do we do this? So we apply pressure and we count 1001, 1002, 1003, 1004, 1005. So roughly, to say 1001, it takes 1 second. That's why we use that. Okay. So press until you count 1001 and then release and again count 1001, 1002, 1003. And the full whatever blanch that you created should refill, should become pink within your 1003. That is within 3 seconds. So if your CRT is less than 3 seconds, then that means the baby's perfusion status is good. So this is how we do check CRT. So there are other signs of shock. For example, peripheral pulses you can check. Okay. And color of the baby. Baby may look pale or cyanosed. Mottling. Okay. Mottling is a very common sign of shock. Cold extremities and decreased urine output, lethargy or augmentation. And the last sign is, as we said, hypotension. So these are the other signs of shock. So tachycardia, prolonged capillary refilling time more than 3 seconds, low volume pulse, pallor, mottling, cold peripheries, okay, decreased urine output, lethargy or augmentation, and last sign is low blood pressure. And as we already discussed, low blood pressure is a late sign of shock. Okay, and the other thing is like the CRT, prolonged CRT and mottling, all these can be seen in hypothermia also. If the baby's body temperature is low, that is less than 36.5, that can also cause mottling and prolonged CRT. That should also be, the temperature also you should check before making sure that it is shock or hypothermia. Okay, so how do you manage shock? Always, 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 first is A. So in older children, you say ABC, right? Airway, breathing, circulation. In newborn infants, we say TABC. It is temperature, airway, breathing, circulation. Because hypothermia itself is a killer. Okay, if the baby's temperature drops very low, that itself can kill the baby. It causes mortality. So temperature is very important in a newborn infant. And newborn babies cannot maintain their body temperature on their own. Okay, so always any sick neonate, please check temperature and make sure the temperature is between 36.5 to 37.5, which is the normal temperature. So first is temperature and next is airway and breathing and circulation. Okay, so like you know how to check airway, breathing and all, no? So count the respiratory rate, make sure that there is not much retractions, make sure baby is breathing. And circulation, as we already said, check for the peripheral pulses, check for CRT, see what is the heart rate. Okay, ask the mother when the baby passed urine last. Okay, check all the signs of perfusion. And if you find hypothermia, you have to warm the infant. And if you find hypoxia, so give oxygen. So the target oxygen saturation in a newborn infant is 91 to 95%. Okay, hypoxia is very bad for a newborn. At the same time, hyperoxia is equally bad, especially in preterm infants. Okay, or very do not do not aim or do not even like target a saturation of 100% in a newborn infant. Always target saturation in a newborn infant is 91 to 95%. And hypoglycemia, we already said we have to maintain blood glucose more than 45 milligram per deciliter. Then, so these are general things, okay? So correct hypothermia, correct hypoxia, and correct hypoglycemia. Any baby in shock, may always be hypothermic, hypoxic, and hypoglycemic. So checking these three is very, very important. In specific management, we have to restore the perfusion, which is very important. So usually what we do is we give a bolus, like your older children only, okay? So, but in older children, usually you give 20 ml per kg bolus, right? In newborn infants, we give only 10 ml per kg bolus. And bolus in a neonate is always normal saline. We do not use any other fluid to give fluid bolus in a newborn infant, not even oral, okay? So the preferred fluid in a newborn is only normal saline. Normal saline, you give 10 ml per kg over 30 minutes. Again, it is not like rapid push in older children. Okay, even if the baby is in shock, the 10 ml per kg you will give over 20 to 30 minutes. Don't give a rapid push. Okay, so for example, you have a 3 kg baby, 10 ml per kg means 30 ml. So you'll give 30 ml of normal saline over 30 minutes. Okay, and then you will have to assess the baby for again clinical signs, whether the CRTs, capillary refilling time is improving, whether the heart rate is reducing, everything. So if you see some improvement, but the improvement is only partial, you can give one more bolus. So you give a second bolus, another 10 ml per kg of normal saline. So usually we don't give more than 2 boluses in a newborn infant. After 2 boluses also, if the baby is still going for inotrophs. Okay, so after 2 bolus, the baby is still having poor perfusion, start with your vasopressor support. Okay, so any shock in a newborn infant is almost always mixed shock. Okay, there will be some hypolemia, there will be some myocardial dysfunction, and there will be some peripheral vasodilatation due to like vasoplegia. So all these components will be there. And the commonest inotrope or vasopressor used in newborn infant, dopamine. Okay, because dopamine affects all the 3 components like preload, contractility, and afterload. So all these are affected by dopamine and it works well in newborn infant. And we usually start at 10 microgram per kg per minute. And if there is no improvement with 10 microgram, then you can increase up to a maximum of 20 microgram per kg per minute. And how fast I will increase? Increase every half an hour, every 30 minutes. So start at 10. After 30 minutes, no improvement, increase it to 15. After 30 minutes, no improvement or less improvement. I mean, there is improvement, but not adequate. Increase it to 20. Infusion rate of dopamine is 20 mg per kg per minute. Okay, how do we calculate dopamine? So, for example, you have a 2.5 kg baby, and I want to give. So, how much dopamine is totally required? 10 into 2.5, which is 25 microgram for each minute. So, for 1 hour, 25 into 60. Okay, so that is 1500. So, if you for 1 full day, that per hour microgram into 36 microgram per day. Okay, 36,000 microgram is nothing but 36 milligram. And 1 ml of dopamine has 1 ml of dopamine has 40 milligrams of dopamine. So if I want 36 milligram, then I have to take 0.5. Okay. So for 36 milligram, I have to take 0.9 ml of dopamine. Okay, so as we already said, this again same. So if you are putting in a burette set, put only the 8 hours dopamine in the burette set. So for 8 hours, the amount of dopamine that will be required is 12 milligram or 0.3 ml. Okay, so if we calculate this, so our baby's weight is 2.5 kg and I want to give 10 mics per kg per minute of dopamine. So 10 microgram per kg is equal to 10 into 2.5. So just 25 microgram. Okay, and 1 minute, for 1 minute, 25 microgram. So for 1 hour, how much? 25 into 60, just 1500 microgram. So for 1 hour, it is 1500 microgram. So for 1 day, it is how much? 1500 into 24. So it is 36,000 microgram. So 36,000 microgram is nothing but 36 milligram. And 1 ml of dopamine has 40 milligram of dopamine. So if 1 ml is 40 milligram, then to get 36 milligram, I need 0.9 ml of dopamine. So for this baby, I have to give 0.9 milligram of dopamine, 0.9 ml of dopamine over 24 hours. Okay, so what will I do with this? So take 0.9 ml of dopamine and add 23.1 ml of some other fluid. It can be either 10% extrude or normal saline depending on whatever is available. So make it a total of 24 ml fluid, and then you can run it at 1 ml per hour. So that will give 10 microgram per kg per minute. So understood? So totally here we calculated the baby needs 0.9 ml of 0.9 ml of dopamine in 24 hours. So to the 0.9 ml, you add 23.1 ml of any fluid, either 10% dextrose or normal saline. So to make it to a total of 24 ml. So that 24 ml you can give in 24 hours at the rate of 1 ml per hour. Okay, so it means if we add 0.9 ml of dopamine in 24, or if you don't want to be so precise, you can even add it as 24 ml also. It will be a little more, but it's okay. To add it to 24 ml fluid and give it at the rate of 1 ml per hour, it will give 10 microgram per kg per minute. Or if you have an infusion pump, you can set the infusion rate also at 0.3 ml per hour. Okay. More important than starting an inotrope is monitoring the ongoing status of the baby, which is very, very important in any baby on inotropic support. So monitor the newborn status of the perfusion of the newborn. So check the heart rate, CRT, pulse volume, and if possible, non-invasive blood pressure monitoring. So make sure that all the signs of poor perfusion are improving. Okay. So we already said, no? So every 30 minutes you have to reassess. So we have started at 10 mics and 30 minutes we are reassessing. We feel that the shock is not fully improved. So increase it to 1.5 ml per hour. So 1 ml per hour was equal to 10 microgram per kg per minute. So 1.5 ml will be 15 microgram, correct? So after half an hour, increase it to 1.5 ml per hour. Still no improvement. After half an hour, increase it to 2 ml per hour, which is equal to 20 microgram per kg per minute. So this will be the maximum dopamine that you can give. Okay, so and as we said, as long as the infant is on dopamine drip, you have to monitor the circulation. That is very, very important. Okay, and then, okay, so I have given up to 20 microgram per kg per minute of dopamine, which is the maximum dose. Still, baby is in shock. What can I do? I have to add the next inotrope, which is usually dobutamine. Okay, and dobutamine improves cardiac output and decreases vascular resistance. So it is it is a vasodilator, whereas dopamine is a vasoconstrictor. Okay. So dobutamine, we said dopamine 1 ml is 40 milligram, whereas dobutamine 1 ml is 50 milligram. This is the only difference. Otherwise, all the other calculation, whatever we did for dopamine, same way you have to calculate for dobutamine also and start the infusion. Okay. So, and then dobutamine also same thing. You start at 10 microgram, no improvement. After half an hour, we increase it to 15. No improvement. After half an hour, increase it to 20. So maximum is again 20 microgram per kg per minute. Okay. After reaching maximum dose of dopamine and dobutamine, if the baby is still in shock, then we can give steroids because it can be a relative adrenal insufficiency. Okay. Whenever there is a relative adrenal insufficiency, your inotropes doesn't work properly. You have to have steroids for you to get the response to the inotropes that you are giving. So when you have given maximum doses of 2 inotropes, still the baby is in shock, you have to give steroids. What steroid to give? Hydrocortisone. How much to give? 1 milligram per kg every 8 hours. Okay, and you can give it for 48 to 72 hours, like for 2 to 3 days, you can give 1 mg per kg per dose, 8 hourly for 2 to 3 days. Okay, unresponsive shock. So we have given everything, but still baby is not responding. You have to consider all the other causes like hypoglycemia, hypoxia, hypothermia, hyperkalemia, anemia, severe sepsis, pneumothorax, cardiac tamponade. All these other causes you have to consider. And consider blood transfusion. So baby is in shock, okay? Baby is hemodynamically unstable. So in such babies, if the hemoglobin is less than 12 grams, then you can consider blood transfusion also. And if the baby is not responding to whatever treatment you are giving, please stabilize the baby and shift the baby to the higher center. Timely referral is very, very important in case of a sick neonate. But before shifting the baby, make sure the baby's temperature is okay, oxygenation is okay, and baby is maintaining blood glucose levels. Okay, so now what are the therapeutic endpoints? Treatment should be modified as per the assessment and response. So what is our therapeutic endpoint? We have to achieve all the signs of adequate perfusion, like the capillary refilling time should be less than 3 seconds, heart rate should be normal, pulses should be normal, pulse volume should be normal, the extremity should become warm, blood pressure should be normal, and urine output should be more than 1 ml per kg per hour. So when all the criteria are met, that means we have corrected the shock. Okay, now how do I wean vasopressors? So I have started dopamine, dobutamine and gone up to maximum dose. So now how will I wean? Usually after starting all the inotropes, once we achieved this therapeutic endpoint, okay, once we have corrected the shock, then leave the baby alone for 4 to 8 hours or 6 to 8 hours, okay? Because only after so much of treatment, baby's perfusion has just stabilized. Baby will need some time to recover, okay? So for 6 to 8 hours, continue all the inotropes as such. After 6 to 8 hours, start tapering the inotropes. While tapering, same thing only. So we started with 10, 15, 20. So from 20, you come down to 15 and then 10, you can come to 5 and then stop. So 20, from 20, 15, 10, 5, stop. Every half an hour or even like usually we don't like wean so fast in newborn infants like in older children. So you can wean every 2 hours. That is a very safe option because baby for your every weaning baby has to adjust. Okay. So grading increasing, you can increase in every 30 minutes. But when you are coming down, you have to come down once in every 2 hours. That is very safe. Okay. So every 2 hours you decrease by 5, 5, 5 and then stop. So first, always the last inotrope has to be weaned first. So first we started dopamine and then we started dobutamine, right? So while weaning, you taper dobutamine first. So dobutamine you wean from 20 to 15 to 10 to 5 every 2 hours and stop. And then you start weaning dopamine. So 20 to 15 to 10 to 5 and then stop. And after stopping also, you have to monitor the signs of perfusion. Okay. And how do I monitor? Any baby on inotropes should be monitored at least every 2 hours. In fact, you have to monitor much more than this also if the baby is more unstable. So what all I will monitor? Temperature, heart rate, respiratory rate, saturation, capillary refilling time, mean blood pressure, urine output, and then Downey score. All of us know Downey score, no? And then Levine score or any score to monitor the sensorium or the mental status of the baby. Okay. Then blood glucose levels, serum electrolytes like at least once in a day at the max, like to the minimum, and calcium also, and blood urea and creatinine. And urea creatinine, especially if the baby is oliguric. Okay, so the key messages for the shock would be, so we have to monitor all sick babies for early signs of shock. So please do not rely only on blood pressure. Low blood pressure is a very late sign of shock in newborn infants. And start treatment immediately if shock appears. Okay, so treating shock, you have like the usual algorithm is give a bolus. Bolus is 10 ml per kg of normal saline over half an hour. Okay, and if there is no response, we can give one more bolus. Okay, another 10 ml per kg of normal saline over half an hour. So maximum only 2 boluses. After 2 boluses, if there is still shock, you have to start inotropes. Inotropes first is dopamine. Start at 10, increase to 15 and maximum 20. After that also if there is still shock, start dobutamine. Dobutamine also again start at 10, increase it to 15 and then 20. After dopamine, dobutamine, if there is still shock, then you can consider giving steroids, which is hydrocortisone. Hydrocortisone 1 milligram per kg per dose, 8 hourly. Okay, so this is shock treatment. But apart from shock treatment, the supportive care is very, very important. That is correcting hypothermia, hypoglycemia, and hypoxia are all very important. And ongoing monitoring is very, very important in a baby who is being managed for shock. Thank you. Any doubts? Okay, so dopamine dose. Okay. Okay, so we'll start with the first question regarding fluid management. Neonatal weight of below 1.5 kg or above 1.5 kg achieve 150 on day 7. Up to how many days of life we can continue the same maintenance fluid 150 and then shift to 100 ml per kg. No, we don't use holiday Sager formula in newborn infants. Okay, so we usually give 150 ml per kg per day only. 28 days or 3 months. Yeah, beyond 3 months, you can definitely reduce it to 100 ml per kg per day. But mostly babies will not need fluids for such a long time. Okay, we'll be able to take the baby onto feeds. Once you, like how we discussed, no, like you start fluids, but then you start feeds and then keep increasing the feeds. When the baby reaches around 80% of the fluids as feed volume, you can stop the fluids and then keep increasing the feeds. Feeds, you can easily go up to 160 or even 180 ml per kg per day in preterm babies. And for term babies, 150 ml per kg per day of feeds, you can definitely give, not a problem. Holiday and Sager formula, we don't follow in newborn infants. Okay, hope like that answers your question. Dopamine slide, I'll show 1 second. So this is the dopamine calculation. Okay, so basically we have to give 10 microgram per kg per minute of dopamine. Okay, so 10 microgram per kg, so per minute. So this baby's weight is 2.5 kg. So 10 into 2.5, just 25 microgram for 1 minute. So if you want to convert it into hour, you have to multiply it by 60. So 25 into 60, 1500 microgram for 1 hour. And you want for 1 full day, right? So 1500 into 24. So that is 36,000 microgram. 36,000 microgram is nothing but 36 milligram. Okay, and 1 ml of dopamine contains 40 milligram of dopamine. So if 1 ml is 40 milligram, then to take 36 milligram, I have to take 0.9 ml. And the 0.9 ml you reconstitute to make 24 ml fluid so that you can run it at 1 ml per hour to get 10 microgram per kg per minute. Same calculation only for dobutamine also. Only difference is dobutamine 1 ml has 50 milligram. Okay. So up to here, this 3600 microgram or 36 milligram, it is the same. But it will not be 0.9 ml because 1 ml has 50 milligram dobutamine. So dobutamine will be only 0.7 ml. For the same 36 milligram, you have to take only 0.7 ml of dobutamine. Rest all everything else is the same. Okay, then post cardiac arrest resuscitated baby, what is the vasopressor? What is the starting dose? Okay, so post cardiac arrest, we are also worried about the heart rate and contractility. That is so heart is our main focus there. Usually post cardiac arrest, we start only adrenal infusion. Okay, but it is not you can start dopamine also, but like dopamine may not be adequate for post cardiac arrest. Adrenaline infusion is a better option. Starting dose, it varies. Usually you can start at 0.5 milligram per kg per minute, microgram per kg per minute, and you can go up to 1 or even maximum of 2, but rarely we go up to 2 mics per kg per minute for adrenaline. 1 mic should work well. Okay, start at 0.5 and then you can increase gradually, depending on the severity of shock or how the baby is after cardiac arrest. Why insulin syringe? No, I didn't say anything about the insulin syringe. I said about the burette set. Okay. Does the neonate mandatorily require respiratory ventilator support while treating septic shock? No, not really. It is not like older children. Sometimes in older children, if the child requires multiple inotropes, we tend to intubate. In a newborn, it is not at all like that. Okay. Baby can be maintained on CPAP itself. Even a baby on multiple inotropes. Okay, can be managed on CPAP. No problem at all. If the baby is respiratory wise, if baby is okay, you can very well keep the baby on CPAP. This happens very often in asphyxia. Okay, asphyxia, baby may have severe myocardial dysfunction and baby may need dobutamine, adrenaline, multiple inotropes also. But baby may be breathing well and baby may be maintaining oxygenation and carbon dioxide on CPAP itself. Okay, so in such scenario, you can definitely continue CPAP. Even for septic shock, just like that. So if the baby is stable on CPAP, you continue CPAP. No need to ventilate the baby just because baby is requiring multiple inotropes. Please tell about dehydration correction again. For example, if day 4, birth weight 2.5 kgs or 60. Okay. So dehydration correction, as we already said, there are 3 components. 1 second. Okay. So dehydration correction, there are 3 components. One component is for correction of dehydration. Second component is the normal maintenance fluid for that baby. And third component is ongoing losses. Okay. So this dehydration may be due to anything. It may be due to diarrhea or it may be due to repeated vomiting, whatever is the reason for dehydration. Okay. So let us take diarrhea because that is one thing we can easily understand. For example, you have a day 5 old baby, okay, term baby, day 5 of life, and baby is coming with some dehydration. Okay. Or we will take it as weight loss. Baby is coming with 20% weight loss. Okay. So what you do is, so for day 5, for a term baby, will require 60, 75, 90, 105, and 120, correct? So 120, normal maintenance fluid for this baby is 120 ml per kg per day. Okay. So that also you have to give. And the baby is having 20% dehydration. So up to 10% weight loss is acceptable. So remaining 10% is extra. So for the 10%, you have to give, you have to correct the 10% of weight. Like for the 10%, you have to give extra fluid. Usually, we don't equate it to volume, but you can take it as some dehydration also if you want to correct like that. Or sometimes what we give is we give 50 ml for the dehydration correction, we take 50 ml per kg as the volume that has to be given. Okay. This is only a rough, there is no like what to say exact number of this much percent dehydration. So this number, there is nothing like that. Usually for 10% dehydration, you can give 50 ml per kg for 24 hours. So again, already you have to give 120 ml per kg. This another 50 ml per kg. And then if the baby has ongoing diarrhea, okay, for example, baby passes some 5 large volume stools. For each stool, you take it as 10 ml per kg. Okay, so 5 stools means that is another 50 ml. So 50 plus 50 plus 120. So the total fluid that we will be giving to the baby is 220 ml. So this is how we calculate for dehydration correction with the ongoing losses. Hope this is clear now. Then can inotropes and other drugs be given through three-way cannula? Yeah, it's a very good question. There are a lot of drugs that are incompatible with inotropes. Okay, so whichever drug you want to give, you have to check the compatibility. So use a reliable source like Neofax or Lexicom. Usually we use Neofax. Neofax PDF is available, or you can use Harriet Lane also. Harriet Lane also gives about the compatibility, I think. Usually we use Neofax. That gives us which drug is compatible with what. Okay, so please check the compatibility before giving through the three-way cannula. If the other drug, whatever you are giving, and the inotropes are compatible, then you can definitely give. There is no problem at all. Okay, can inotropes and blood be transfused through one cannula using three-way? Yeah. Ideally, blood should not be given with any other fluid. That is the general recommendation. Because the fluid that we are giving is always hypotonic. With that, the blood will get mixed and there may be a risk of hemolysis and other things. Okay. But sometimes in a very sick neonate where you do not have a second cannula, sometimes we have given. Okay. But in such a scenario, like the other fluid that you are giving, so for example, you want to give dopamine infusion and blood, okay? So then put the dopamine in normal saline instead of 10% dextrose because 10% dextrose is a hypotonic fluid. Okay, it is not good to mix blood and hypotonic fluid. So use normal saline. So you put your dopamine in normal saline and infuse it along with the blood. That is okay. But if you don't have any other option, you can definitely give. It's not a problem. Thank you, Dr. Sasra. Shrikant. Any other doubts? Thank you, Dr. Arvind. Dr. Murugesan, you're there? Okay.
Yeah, hello.
Hi, you want to give calculations or what?
I think we have some calculations, 4 or 5 questions. So whoever is remaining, no, you can just put your answer in the chat box. It will be good exercise for you. Can I share the screen?
Yeah, please. See, do once, then only will like you will not make mistakes. Now, like while just listening, you may think that you have understood everything, but only when doing the calculation, you will know like where like your doubts. Okay, so you can clarify now itself.
I think somebody asked regarding insulin syringe. I think that it is given in the guideline to use insulin syringe for taking ionotropes. The idea is to
Oh,
use a
okay.
1 ml syringe. So
Yeah.
that is what it was probably meant.
No, please do not use insulin syringe. Insulin syringe conversion to ml is very confusing. Use a 1 ml syringe because
Yeah.
we are going to do everything in ml only, no? So 1 ml syringe is good enough.
So are you able to see the screen, ma'am?
Yeah, yes.
Okay. So which of these neonates will have maximum fluid requirement? You can type one of these options.
Maximum fluid in terms of per kg, correct, no?
Maximum fluid
ml per
requirement.
kg per day.
Hmm. Can type your answer in the chat box. Yes. Okay. A, C. Okay. Most of you have replied A or C. I think A is the correct answer. So because the fluid requirement is maximum in the most premature babies because they have maximum insensible water loss. So the correct answer is 25 weeks, 650 gram baby. Okay. So next question. Out of the total energy intake, how much energy is stored by the neonate? Can choose one of the four. So out of the total calorie requirement, so some of it is spent for VMR, some of it is wasted in the excreted, some of it is used for synthesis, some of it is stored. So how much of the energy is stored by the baby? Is the question. So B. Okay.
We said
So,
storage is nothing but growth, no? So for growth, how much calories is required?
okay. Most of them have said B. The correct answer is C. 20 to 30 kilocalorie per kg per day. This is the amount which is stored and used for growth. Okay. So next question. So calculate fluid requirement and rate in ml per hour over 24 hours for a baby who is 1.4 kg and a preterm 32 weeker neonate for day 3 of life. So based on how much we increment daily, day 1, day 2, day 3, how much will we give for this baby, what fluid and what rate? Okay, A, B, A. Yeah, I think most of you have got right. The correct answer is A. So 110 ml per kg will be for this baby based on 80, 95 and 110. And like already madam told, The daily increment of 15 is not hard and fast. It depends on other factors. But for calculation purpose, for this scenario, you can take as 110 on day 3. So we need to add electrolytes also. So correct answer is A. 150 ml ISOP over 24 hours at 6.4 ml per hour. Okay. IV fluids can be stopped once feed volumes of how much ml per kg per day is reached. 150, 100. A, B, B, A, B. So the correct answer is 100 ml per kg, C, or 2/3 of the total fluid requirement, right? Yeah, C. Okay. So the correct answer is either 2/3 of the total fluid requirement or 100 ml per kg. Okay, last question. I think this was shown once again. So how will you calculate the amount of dopamine needed for 24 hours for infusing at 10 microgram per kg per minute for a baby weighing 3 kg? So just multiply 10 microgram into kg will be the weight, 43 mg. A. Yeah, I think the most of them are giving the right answer. So the correct answer is 43 mg, right? You can either use in 20, make in 20 ml, you at 1 ml per hour. Okay. I think we reached the end of the questions. So thanks for your active participation. So if there are no other queries, I think we can finish the session.
Yeah, okay. Thank you all. Thanks a lot.
So thank you so much everyone for extending us the opportunity to host the session. So with all your permission, I would like to conclude the session over here and looking forward to host you again. Thank you.